Generalized anxiety disorder affects tens of millions of adults. The standard of care usually defaults to SSRIs or benzodiazepines, but those therapies come with significant trade-offs, namely high rates of habituation, severe withdrawal protocols, and a heavy burden of side effects. As patients seek alternatives, they often look to phytotherapy, herbal interventions. In clinical psychiatry, these are routinely dismissed. They are viewed as subclinical, driven entirely by the placebo effect, or relegated to the category of a soothing cup of tea. But a 38-week, double-blind, placebo-controlled Phase 3 trial challenged that assumption. It tested a long-term, high-dose, pharmaceutical-grade chamomile extract against moderate to severe GAD. To understand how this intervention actually performs, we have to evaluate it strictly as a pharmacological agent. That requires stripping away the dietary associations and deconstructing the trial's architecture and statistical outcomes. The botanical agent evaluated is Matricaria recutita, commonly known as German chamomile. Extracting the active biochemicals directly from the flower heads isolates a dense concentration of volatile oils. Among these are specific anxiolytics, most notably apigenin, bisabolol, and chamizoline. To achieve therapeutic efficacy, the researchers bypassed standard dietary amounts. The trial utilized strict dosing parameters, 500 milligrams administered 3 times daily, totaling 1,500 milligrams every 24 hours. At these concentrations, the plant extract ceases to be a dietary supplement. It operates as a targeted biochemical modulator of the body's inflammatory and anxiety pathways. Psychiatric clinical trials face a pervasive methodological hurdle. They routinely yield exceptionally high placebo response rates, which makes it incredibly difficult to isolate the true efficacy of the drug being tested. To solve this, the MAO trial implemented a biphasic architecture. They designed a targeted filtration system to identify and remove placebo responders before the main test began. This diagram outlines the approach. Phase 1 was an open-label trial. All 179 participants received the full 1,500 milligram daily dose of chamomile for 12 weeks. The researchers then applied strict criteria to identify a physiological response. A patient was only classified as a responder if they achieved a minimum 50% reduction in their baseline generalized anxiety disorder scores, measured by the GAD-7 index. By the end of those 12 weeks, the original cohort funneled down to the 93 participants who met that strict threshold. This open-label filtration phase ensures that the subsequent double-blind trial is only testing patients who have already proven a physiological response to the extract. The initial placebo spike is completely neutralized. The trial then transitioned into Phase 2, a 26-week randomized double-blind continuation phase. The 93 responders were split into 2 arms. 46 continued on the chamomile extract, while 47 were switched to a placebo. The primary efficacy endpoint measured how these groups tracked over the next half year. The chamomile group maintained significantly lower GAD scores throughout the entire 26 weeks compared to the placebo group. The statistical significance of this anxiety reduction generated a p-value of 0.0032. The researchers also tracked secondary, systemic metrics during the trial. The Verum group saw significant reductions in body weight, with a p-value of 0.046, and blood pressure at 0.0063. These precise statistical markers indicate a sustained physiological and psychological benefit. A placebo effect cannot maintain that level of systemic modulation across 26 weeks. For chronic GAD management, the ultimate benchmark of a therapy is relapse prevention. Over the 26-week follow-up, the top-line data showed that 15.2% of the chamomile group relapsed, compared to 25.5% of the placebo group. This survival curve plots the duration of remission, the window of time a patient remains functional and asymptomatic before a resurgence of GAD criteria. Chamomile nearly doubled this relapse-free window, extending it to an average of 11.4 weeks, compared to just 6.3 weeks for those in the placebo arm. Extending the timeline of remission is a critical clinical victory. It offers patients significantly longer periods of functional stability between acute anxiety episodes. Clinical efficacy is only half of the equation. In psychiatric care, patient compliance often hinges entirely on tolerability. Standard psychiatric medications like SSRIs and benzodiazepines require severe taper protocols and carry intense withdrawal symptoms. The Mao trial compared their findings against these known risks, explicitly noting a lower frequency of discontinuation symptoms for the chamomile extract compared to standard psychiatric drugs. A highly effective anxiolytic only becomes a viable long-term strategy if it possesses a favorable adverse event profile, managing anxiety without creating chemical habituation. This requires clinical caution. The fact that an agent is derived from a plant does not mean it is universally benign. There are strict physiological contraindications. Patients with hypersensitivity or severe allergies to the Asteraceae family, which includes ragweed, chrysanthemums, and daisies, cannot use this treatment. There are also specific pharmacological interaction risks. High-dose chamomile may increase the properties of anticoagulant medications, and it can interact negatively with other sedatives. Furthermore, there is a lack of safety data for pregnant or breastfeeding women, and the extract carries potential estrogenic effects that may interfere with hormonal therapies. The requirement for physician oversight stems from the extract's biological activity. Because these compounds are potent enough to compete for metabolic pathways and receptor sites, they operate as a targeted pharmacology, regardless of their botanical origin. The clinical profile of 1,500 milligrams per day of Matricaria recutita is clear: proval efficacy in moderate to severe GAD, significantly delayed relapse timelines, and a highly favorable safety profile. This hard data contrasts the bias that phytotherapy is incompatible with modern psychiatry. The molecule's origin matters far less than its measurable performance in trials. When subjected to the highest standards of evidence-based medicine, phytotherapy offers a rigorous, data-backed tool for managing chronic psychiatric conditions.